Hello, everyone. First, I want to thank the organizer to give me this opportunity to discuss nutrition in children with the exocrine pancreatic insufficiency. I have nothing to disclose. In this lecture, we will first talk about the normal pancreas, then we will talk about what the exocrine pancreatic insufficiency, EPI, is. Then we focus on EPI evaluation and management. And for pancreas, we all know it sits deep inside the abdomen. It's behind the stomach, and pancreas can secrete pancreatic juice and drain through pancreatic duct. Pancreatic duct fills with a hepatic duct forming common bile duct and has opening in the duodenum. So pancreas is a glandular organ. It has both endocrine and exocrine function. And if you look at histology, this red with the surrounding purple nucleus, those are acinar cells. So on the apical side of the acinar cells, you can see those granules. Those are zymogens containing inactive digestive enzymes. And those zymogens just secreted through pancreatic duct and eventually secreted inside the duodenum. And those pinkish cells are islet cells. It can produce insulin, but not just insulin, also produces glucagon, somatostatin, and pancreatic polypeptide. So adult-sized pancreas can deliver around 2.5 liters of fluid every day. And during meals, the secretion flow can rise almost 20 times higher. Pancreatic fluid is isotonic, slightly alkaline, and it's rich in protein. It contains bicarb, electrolytes, and water. And as we mentioned earlier, acinar cells can synthesize, store, and release digestive enzymes, and it can digest protein, carbs, lipid, and nucleus. The secretion of a pancreatic enzyme is controlled through receptors located on the basal and lateral membrane of the acinar cells. And this process is also through the calcium mediation. The ductal cells can secrete 1 to 2 liters of neutral pH juice, mainly it's water and chloride. It's through the regulation of CFTR and also other membrane channels. So the inactive digestive enzymes secreted inside the duodenum, and the first enzyme get activated is a trypsinogen. It's activated by enterokinase located on the brush border of the enterocytes inside duodenum. Once trypsinogen is activated to trypsin, the trypsin will activate the rest of digestive enzymes. And now the food comes down from stomach, it mixes with active enzymes, and you start food digestion. So what is EPI, exocrine pancreatic insufficiency? We talk about the normal pancreas can secrete digestive enzymes and also bicarb. So the EPI meaning the decrease of this function, so have decreased digestive enzymes and bicarb. It can lead to maldigestion and malabsorption of nutrients. Many pancreatic disorders can result in EPI eventually. And if pancreas parenchyma is compromised more than 90%, then patient can present with steatorrhea. So we know the steatorrhea is now the early sign for EPI. If left undiagnosed and untreated, EPI can lead to poor digestion of food, cause chronic diarrhea, and severe malnutrition and related complications. And it can affect the quality of life of patients. So what are the etiologies for EPI? It can be pancreas related. It can also be part of some systemic diseases. For pancreas-related disorders, cystic fibrosis is the most common reason for EPI. We will talk about cystic fibrosis in just a second. And for patients with a chronic pancreatitis, they may also develop EPI. Some syndromes like Shwachman-Diamond syndrome, Pearson syndrome, Johansson-Blizzard syndrome, and Jones syndrome, EPI can be part of the whole spectrum. And some patients during development may have a hypoplasia of the pancreas or aplasia of the pancreas, so they can also present with EPI. And of course, if a patient undergoes a partial or total pancreatectomy, and they will have EPI. Systemic diseases like diabetes, IBD, or celiac disease, some of the patients may also develop EPI. So I want to just talk a little bit of cystic fibrosis. So mainly because our current understanding and also management of EPI are based on the experience from cystic fibrosis. So cystic fibrosis is the most common life-threatening autosomal recessive disorder in Caucasians, and is caused by the mutations in the cystic fibrosis transmembrane receptor gene, CFTR. And in the United States, there are around 10 million population are heterozygous of a CFTR, and this is a survival advantage. So in the pre-antibiotic era, when there was cholera epidemics, so for those with CFTR mutation, were less likely to develop severe diarrhea and die of severe dehydration. So this is an illustration of cystic fibrosis, and you can see there is a thick mucus just clog the airway, so it can cause lung involvement. And this thick mucus also can block the pancreatic duct, so cause EPI. So you suspect a patient has EPI and you want to do the evaluation. So the early diagnosis of EPI in children still remains challenging, and there are direct and indirect pancreatic function tests we will talk about. So direct tests include secretin stimulated MRI. This one is a non-invasive. It's pretty accurate, however, it's not validated in children yet. So hopefully in the future, this method can be validated, so can widely use this method in different centers. The drilling tubes has its limitation in clinical use. We don't routinely use this method in pediatric population, so I won't talk about the drilling tube. EPFT. It's an endoscopic pancreatic function test. So it's done through endoscopy, so it's invasive. It's considered as a gold standard of pancreatic function test. However, this is invasive, so it's only offered in selected pediatric centers. For indirect tests includes 72 hours of fecal fat test. For this test, you need to record 72 hours of oral fat intake, and you also need to collect 72 hours of feces. And then you measure the fat content in feces, and you calculate the percentage of the fat not absorbed by the GI tract. And if the percentage is above 7%, then you consider the patient has EPI. If those are the infants less than 6 months of age, then the percentage needs to be above 15%. This method is time consuming. And it's not pleasant for the personnel handle it. So we don't routinely use this one at clinical settings, but in selective patients, we still use this method. In clinics, we do see some physicians order one-time qualitative fecal fat test. So you just check stool samples and found there is a fat. But really it doesn't mean anything, because we know in the feces you can have some leftover fat. So one time just showing fat is there really doesn't give us any clues if a patient has EPI or not. For fecal elastasis is one of the most commonly used modality to evaluate EPI. It is relatively simple, it's cost effective. However, the fecal elastasis is not ideal to detect early EPI. Also, when you collect the samples, if a patient has pancreatitis or diarrhea at the time, then you can get the false positive result. For carb-13 labeled mixed triglyceride AC, it's not available in US for children. So for elastase, what is elastase? There are 5 isoforms. Really the biological specificity of this protein is largely unknown. Elastase 1 is a proteolytic enzyme. It binds to bile salts and passes through the guts with a minimal degradation. And the concentration in the feces is much higher than that in the pancreatic juice, so it's dosable in the fecal samples. Elastase reflects the pancreatic output and also correlates with other pancreatic enzymes like lipase, amylase, and trypsin. It's highly stable in feces for up to 1 week if it's stored at room temperature, and up to 1 month if it's stored at the 4 degree. So for patients you suspect for EPI, you send fecal elastase 1. If the number is less than 100 microgram per gram of feces, then most likely this patient has EPI. Then you want to expand your workups and to look for etiologies of pancreas disorders or like other etiologies. And you may want to start crayon and fat-soluble vitamin supplements. If this number is between 100 to 200 microgram per gram of feces, then patient possibly has EPI. You want to closely monitor that. You may repeat the test or utilize other modalities to assess EPI. If the number is above 200 microgram per gram, most likely the patient has a normal pancreatic function. But as I mentioned earlier, this method is not ideal to detect early EPI. So for endoscopic pancreatic function test, EPIFT, so you do endoscopy, you insert scope into the duodenum, and then you inject the patient with a secretin or CCK. It can mimic the physiology stage after patient's eating. So the pancreas juice start to secrete, you aspirate at 5, 10, 15 minutes, and then you check digestive enzymes activities. And then you aspirate the fluid up until 40, 45 minutes, and you check bicarb concentration. So we measure trypsin, amylase, lipase, chymotrypsin. It's not concentration, we measure enzyme activities. And then we measure the bicarb concentration. It's considered the gold standard. However, have to point it out, currently we don't have age-dependent normal range in children. At least this table is from a Cincinnati study group. We use it this table as a reference, but we don't have a normal range to interpret the result. And once you diagnose a patient with the EPI, you need to start pancreatic enzyme replacement therapy. It's called PERT. So PERT can reverse malabsorption, and around 80 to 90% of patients with cystic fibrosis need PERT to avoid malnutrition. And as I mentioned earlier, current understanding for PERT mainly based on experience from cystic fibrosis. And for PERT, porcine pancreas is the usual source of pancreatic enzymes. It has high enzyme activities of amylase, lipase, and proteases. Lipase is the main pancreatic enzyme in PERT. It's also the least stable. It's very sensitive to acid environment and proteolysis. So you can see for PERT products in general, they use lipase units to describe its dosage. Since 2010, there are several PERT products were approved by FDA. There are three types of PERT. The first one is enteric coated. So majority of the PERT products are like those, like a crayon. It's in delayed release form. So enteric coated spheres and microspheres can survive the acid environment in the stomach. And the second type is uncoated enzyme. The only available product is a wild case. So they are sensitive to acid environment. So when you prescribe wild case, you probably want to start PPI at the same time to maximize its activity. And the third type is enzyme cartridge, Realisorb. This one is digestive enzyme designed for patient on tube feeding, including G or GG tube feeding. You connect the cartridge with the feeding tube so the formula can mix with the enzyme and start the digestion. We also need to point out for Realisorb, lipase is the only enzyme in the cartridge. It doesn't have other digestive enzymes. So for the PERT dosage, it's age and weight dependent. For infants, you give 2 to 4,000 units per 4 ounces of formula or breast milk. Less than 4 years of age, you start with 1,000 lipase units per kilo per meal and 500 for snacks. If a patient is more than 4 years of age, you start with 500 units per kilo per meal and 250 for snacks. It's pretty well tolerated in patients. Some side effects including headache, dizziness, abdominal pain, gasiness, or diarrhea. If the dose of a PERT is too high, more than 10,000 units per kilo per day, or more than 6,000 units per kilo per meal, then patient is at a higher risk to develop a fibrosing colonopathy. If a patient failed to respond to PERT, the first thing you need to check is compliance. If compliance is satisfactory, then you need to consider to increase per dose or you start anti-acid medication. Really the purpose is to reduce acid denaturation of the enzymes. And for those patients, they can have other etiologies for malabsorption or malnutrition, so also need to screen for alternative etiologies, for example, SIBO in chronic pancreatitis patients, and to check if there's also other things going on at the same time. And for patients with the EPI, we need to monitor the fat-soluble vitamins, including A, D, E, and K. So I don't have a lot of time to go through the fat-soluble vitamin deficiencies, clinical presentation, and their doses. Just keep in mind it's also age-dependent or weight-dependent for A, D, E, and K. So for water-soluble vitamins, it's reported in patients with EPI, but it remains controversial for supplements for patients with a pancreas disorder. So it's a case by case when we decide if we need to add it. And the patient may also have a zinc or other mineral or trace elements deficiency. We need to monitor that if a patient shows symptoms. And the same thing for essential fatty acid. We need to keep that in mind in patients with a severe malnutrition. Okay, so I will stop here, and I'm happy to take any questions. Thank you so much.